All right, good afternoon, everyone. And Health and Human Services. Our chair is presenting a bill and another committee meeting, so I have the honor of sharing. You're stuck with me today, at least until he gets back.
I thought
Okay.
I was in the wrong place.
Okay. All right, we'll start with our roll. Madam Secretary, please.
Senator Lang. Senator Stone. Senator Taylor. Senator Titus. And Chair Doniate.
Thank you, Madam Chair. Please mark Chair Donyante and Senator Titus present when they arrive. Okay, on our agenda today, we have two bills that we will hear, Senate Bill 250 and Senate Bill 257. We're going to start with Senate Bill 257, and our presenter is in the room. So before we get started, let me go through a little housekeeping. Little house, easy. A little housekeeping. We're welcome here and welcome in Las Vegas. I see we have some folks there. We may even have some people online. Just a couple of reminders. Please silence your cell phones if you would. Speaking of cell phones, thank you. Please silence your cell phones if you would. And then when you come to testify, first of all, if you'd like to testify, please make sure you've signed in and then leave your business card for our secretary, if you will. When you testify, please turn the microphone on, speak loudly and clearly, and spell your last name for the record. We want to get make sure we get that accurately. And also, whenever you speak, we will remind you to say your name again if you forget somehow along the way. We do have a floor session at 5 p.m. that we have to be down at 4:45 today. So most things will be timed today, but it will be fair. Certainly will be fair on either side of an issue. Finally, you'll see committee members have laptops open. We have exhibits and so on in front of us. So as we look at our computers, please don't see that as a sign of inattention or of the lack of respect. So we will get started now. We will come forward. Senator Dondero Loop, please come forward. This is Senate Bill 257, which revises provisions related to autism. Please go ahead when you are ready, Senator and friends.
Good afternoon, Vice Chair Taylor. Thank you so much, and thank you to the committee for having us here. My name is Marilyn Dondero Loop, and I am State Senate District 8 in Clark County, and I am honored to present Senate Bill 257, which revises provisions relating to autism. I have with me here today Dr. Beasley, who is a child neuropsychologist, and I have Dr. Gasper, who is a pediatric specialist. And if I didn't get all that exactly correct, they will most likely introduce themselves in just a minute, because they are an amazing team that works with the Ackerman Autism Center. And behind me, I have Mr. Brian Hager, who is our CEO of the Grant to Gift Foundation. The National Autistic Society defines autism as a lifelong developmental disability which affects how people both communicate and interact with the world surrounding them. Signs of autism can be identified as early as 18 months old, yet most people are not properly diagnosed until 5 years or older. The Centers for Disease Control and Prevention found 85% of children expected to have autism had developmental concerns noted in their records by 3 years old. 42% of them were diagnosed on the spot, 19% were diagnosed within the following 2 years, and roughly 39% went undiagnosed. Sometimes diagnosis were delayed because of difficulty in identifying the symptoms or escaping the stigma and gathering the courage to take the first step to seek guidance. Other times, diagnoses were delayed due to geographic location and the lack of access to specialty providers authorized to conduct autism assessments. According to the Kennedy Krieger Institute, the average wait time for a scheduled appointment can range from 3.5 months to over a year, and even longer in some of our rural areas. This bill authorizes any healthcare provider to conduct a statewide standard for measuring outcomes and assess and evaluate people with autism spectrum disorders if it is within their scope of practice. This expands the number of healthcare providers that can conduct these assessments, therefore expanding access. With that, I will briefly walk you through the sections of the bill, and then I will ask my experts here to come into the process and the conversation. Section 1 defines the term provider of health care for those purposes. Section 2 prescribes the applicability of that definition. Section 3 removes the requirements that the statewide standard includes a specific protocol, a standardized assessment instrument, and an evaluation. This section instead requires the statewide standard to align with best practice guidelines in addition to direct observation and an assessment with healthcare provider to measure behaviors consistent with autism spectrum disorder. This section authorizes any healthcare provider to conduct such direct observations and assessments if it is within their scope of practice. Section 4 makes similar revisions relating to early intervention services provided by the Aging and Disability Division of the Department of Health and Human Services for children with autism spectrum disorders. Specifically, Section 4 replaces references to an evaluation of a child who may have autism spectrum disorder by the division with references to an assessment of such a child, and authorizes any healthcare provider acting within the scope of practice to conduct such an assessment in addition to early and periodic developmental screening. Sections 5 through 10 remove requirements that for certain plans of health insurance coverage to be required, specified healthcare providers make a diagnosis, development treatment plan, and provide care. Instead, sections 5 through 10 require certain plans of health insurance to cover such diagnosis and treatment if the diagnosis, development of the treatment plan, and treatment are performed by any provider of health care acting within his or her scope of practice. Sections 5 through 10 also require an insurer to accept any diagnosis of autism spectrum disorder rendered in accordance with the statewide standard pursuant to Section 3. So with that, I would like to turn it over to my experts. We'll start with Dr. Gasper. Thank you very much.
Dr. Mario Gaspar de Alba, Gaspar, space DE, space ALBA. Thank you, Senator Dondero Loop, Vice Chair Taylor, and members of the committee. My name is Dr. Mario Gaspar de Alba. I'm an Associate Professor of Development and Behavioral Pediatrics at the Kirk-Kerkorian School of Medicine and the Medical Director at the Grand Gift Ackerman Autism Center. I've been practicing in my specialty for almost 15 years and in our state since 2013. I've chaired our state's Autism Commission. I train pediatric residents in the diagnosis of autism and other neurodevelopmental disabilities, and I work with families and children affected by autism every day I'm in clinic. Current legislation around criteria for diagnosing autism spectrum disorder was established in 2009. At that time, the incidence of autism was 1 in 110 children, less than 1%. The current rate of autism as of 2024 is 1 in 36, or 2.78% of children. Based on that number, we can estimate that about 21,000 children in our state have autism. The National Autism Data Center at the A.J. Drexel Autism Institute reports the average age of diagnosis of autism in a child in Nevada is 5.5 years, compared to the national average of 5 years. That is higher than any state that we border. This is a problem because studies have also shown that in some cases, autism can be diagnosed as early as 1 year of age. We know that early intervention leads to better outcomes. Quoting from a 2017 study, the importance of receiving an early diagnosis of autism spectrum disorder and subsequent early intervention is well established in the literature. Late diagnosis is associated with increased parental stress and delays early intervention, which is critical to positive outcomes over time. This is particularly important because studies have found that interventions implemented before age 4 are associated with significant gains in cognition, language, and adaptive behavior. Similarly, researchers have linked the implementation of early interventions in autism with improvements in daily living skills and social behavior. Collectively, this evidence suggests that early diagnosis and intervention are imperative in the long-term trajectories and quality of life for children with autism spectrum disorder. For this reason, the American Academy of Pediatrics has long recommended screening all children for symptoms of autism through a combination of developmental surveillance at all visits and standardized autism-specific screening tests at 18 and 24 months in their primary care visits. The AAP offers many resources to primary care providers and other clinicians that they can use to make an autism diagnosis in the primary care setting. They report, and I endorse, the following 4 benefits of a primary care autism diagnosis. First, reducing wait times for patients. I believe there's only one other developmental behavioral pediatrician in our state and only a handful of neuropsychologists. This means wait times for a comprehensive assessment as required in current law are long, and any lost time is lost opportunity for better outcomes. Second, improving continuity of care. A patient and a family can be seen much more often by their primary care provider than by a specialist. Third, reducing disparities in access to diagnostic services. Patients who are underinsured or less likely to be insured, often our most vulnerable children, are also less likely to be seen by a specialist. Assisting families in better understanding their children's strengths and needs for support. Number 4, a primary care physician is more immediately familiar with not just a child's strengths, but also their unique needs of every family. Removing prescriptive language surrounding the diagnosis of autism reduces the administrative burdens on providers, especially primary care providers, and facilitates their effort to provide more timely access to needed support services. Eliminating this language will also facilitate insurance coverage of the requisite evidence-based therapies. Primary care providers and other appropriate clinicians are adequately trained to make an autism diagnosis. They will continue to have access to specialists like me and neuropsychologists like Dr. Beasley, who can perform comprehensive assessments if and when they are clinically indicated. This will reduce our wait times and allow us to focus on and serve those patients and families who require a higher level of evaluation and support in a more timely manner. Thank you for your time and interest.
Good afternoon. My name is Dr. Julie Beasley, Beasley, and I'm a licensed psychologist specializing in pediatric neuropsychology. I'm the clinical director at the Ackerman Center, and I am an administrative faculty at the Kirk Kerkorian School of Medicine. I grew up here in Las Vegas, or not up here, down there in Las Vegas, and I completed my undergraduate and graduate work at UNLV. Following my doctoral work at Arizona State University, I returned home to Las Vegas in 1997 to practice, and I was the first child neuropsychologist to work with children under the age of 5 with autism. I have had the privilege to work with children, teens, young adults, and their families, now grown-up adults, and their families for the past 27 years. Just 8 years ago, Dr. Gaspar de Alba, our pediatric neurologist, Dr. Ruman Ahad, geneticist, Dr. Colleen Morris, and myself joined together with Grant-A-Gift and Gary Ackerman in developing one of the only centers for families with autism to receive diagnosis, treatment, and case management through a multidisciplinary approach in Southern Nevada and within our state. As Dr. Gaspar de Alba has described, the significant incidence, impact, and need for services that they only continue to grow. The original 2009 legislation, NRS 427A.872, put Nevada among the first states to require insurance coverage of autism services across our nation. This important law created access to autism diagnosis and treatment, and it is crucial to where we are today. But since that time, the autism community has been hard at work for Nevada's children to receive appropriate and timely diagnosis and treatment. While we have made significant gains over the past 16 years, the need for autism services continues to outdistance state and local community resources. SB 257 is a critical step towards improving access to care and reducing the barriers for individuals with autism and their families. By aligning regulations with current standards of care, we can ensure that Nevada's children receive the timely diagnosis, which is the pivotal first step into treatment. Within the prescriptive language of the original bill, we have seen the use of comprehensive evaluations to be used as requiring a neuropsychological evaluation before treatment can begin. I'm a neuropsychologist. That is not how the steps or the path is supposed to go. This creates a very lengthy wait lists in the state. And it's a state, and we have a state where our provider-patient ratio to meet the need is not there. SB 257 does not exclude developmental, neuropsychological, or psychological evaluations, which will always be needed by specialized providers. As one of those specialized providers who has seen my own wait list create unbearable barriers to families, we simply had no choice but to address this portion of the original legislation. To clarify, as outlined in NRS 629.031, the term provider of health care encompasses a broad range of medical and behavioral health care professionals. While this list is extensive, only specific professionals such as pediatricians, psychiatrists, developmental pediatricians, family medicine practitioners, nurse practitioners specializing in pediatric or neurodevelopmental care, and psychologists possess the necessary training and qualifications to diagnose autism spectrum disorders within their respective scopes of practice. These professionals adhere to rigorous legal and ethical standards that ensure that they practice within their competencies. Furthermore, their ability to diagnose autism spectrum disorders is regulated by their respective professional licensing boards, which oversee the scope of practice and adherence to the guidelines. We ask for your support in helping us to continue move forward in the care of individuals with autism and their families. Thank you.
Thank you very much, Madam Chair. And with that, we are open to any questions you may have.
Thank you, Senator. Looking to the committee to see if any committee members have questions. Dr. Titus? Senator Titus, how about that?
Thank you, Madam Chair. I thank you for being here, and I appreciate the presentation. I have a couple questions. First, nothing at this point in law prevents a medical provider from diagnosing autism at this point in time, does it?
Sure. Dr. Gaspard Alba, for the record. So it doesn't specifically say, but the prescription of a comprehensive evaluation has been taken to mean things that include adaptive testing or cognitive testing, things that not all medical providers, really few medical providers do, which is more in the realm of psychology. So by requiring the comprehensive evaluation, that does eliminate the possibility of other primary care providers, especially, to perform those evaluations or make that diagnosis.
But currently, there's no law against other providers. First question, thank you. And then in Section 3, if you're looking at the actual bill, it would be line 21. It requires direct observation by a provider of health. Does that mean in-person observation, or could this be done through telehealth?
So again, Dr. Gaspard Alba, for the record, direct observation could also include telehealth. Yes.
Because one of my concerns with the bill, with all, I am engaged in this process. I literally am the physician for Lyon County that does all the IEPs for Lyon County. So I deal with this issue when I go home at night looking at IEPs after I leave this building. And so I get it. My daughter's a school psychologist. We understand this process and the delays. But I worry that a bill like this, you get early diagnosis, but it doesn't necessarily mean you have more access to care. So you have a diagnosis. It doesn't mean there's more of us or more of you out there. You're having more diagnosis of this, and early diagnosis, I think, is critical. But again, I don't see anything where it really actually increases the access to care. If nothing else, it might create longer waiting lists, because now you have more people diagnosed with it, and then that timely referral is a concern, and I don't see that the bill fixes that.
Okay, there's a couple layers there.
Doctor, would you mind
I'm
giving us
sorry,
your name for
yes.
the record?
Julie Beasley, for the record.
Thank you.
Okay. When we set out to look at this bill, what has occurred as part of it is that Dr. Gaspar, as a medical doctor, can make the diagnosis, but that has been not enough, and insurance companies are requiring a comprehensive neuropsychological evaluation, of which we have very few providers across our state. And so what happens is that they may get that early diagnosis, but by continuing to have very prescriptive language in here, it stalls them into the initial treatment work that they need to go through. It doesn't curtail that work, but it doesn't demand that and restrict. Dr. Gaspar has a different approach to the same diagnostic process And I have one as well, but I am a psychologist, and I work within my scope to get there, which is a more comprehensive evaluation. Dr. Gaspar is a medical doctor, and he is doing the same thing. So what we're asking is to be very clear that that prescriptive language telling providers out what exactly to do has actually lengthened. We've actually seen a U form in early diagnosis. We were doing better when we opened Ackerman Center, and then we have lost ground. So we were doing early diagnosis, which means into early treatment. It may not always mean immediate access into that treatment, but you're sooner into the intervention, maybe the wait list sooner, and we can start to work with families and teach them what is going on with their children. And there are interventions that they can do within their homes as well, not just community-based interventions.
I thank you for that, and I get all of that. But the issue to me again is what I'm hearing. The real problem lies with reimbursement from insurance companies and their mandate for these certain diagnoses before they'll authorize it and pay for them. And I'm not sure that this bill actually. I blame everything on insurance companies. I gotta tell you. But just having said that, I think that's the real issue here is, and I don't have a problem with changing provider of healthcare. We certainly know nurse practitioners, and I'm an MD, family practice board certified type of thing. But there's a spectrum of healthcare providers who can make this diagnosis, get that ball going earlier, the better, to get that treatment. What I'm worried about is that next, do we really get more access to care and more treatment? And to me, the barrier to me is the insurance wall about that diagnosis. And I hear what you're trying to do, but I just worry the insurance companies, this isn't going to be enough for the insurance companies. That's my concern. Thank you, Madam Chair.
Thank you, Senator Titus. Senator Stone?
Thank you very much for the presentation. I appreciate it. And there are some terms in the bill. Standardized assessment instrument, is that your neurological testing that you're talking about that is very comprehensive and is taking time, and we're trying to abbreviate that so that we can get more kids diagnosed and ultimately into treatment?
In the original, Julie Beasley for the record, in the original language back in 2009, the bill was prescriptive as it needed to be. Best practices is less prescriptive and having specialized professionals do their scope of practice for that diagnosis. So to not have that comprehensive evaluation be a huge barrier, and that is certainly what's happening, has happened, and continues to happen across our center and across the state.
So that if I can follow up, so and then instead, we're going to be going with direct observation and assessment, which is going to open up the variety, if you will, of healthcare providers that can make this early diagnosis so that we can hopefully get people into care. Is that correct?
Do you want to do that, or you want?
Yeah, so Dr. Gaspard Alba, for the record, yes, essentially that's what it is. So removing that prescriptive comprehensive evaluation to use any number of potential standardized assessments or direct observation or anything else that a provider may need to meet the criteria as listed in the Diagnostic and Statistical Manual 5, which has the criteria for an autism spectrum disorder diagnosis.
Okay, and so to follow up again, if we get to that specific diagnosis, this is going to be a mandate that insurance companies will cover autistic services and not require the comprehensive testing that has been required in the past.
Yes, sir. That is correct.
Okay, thank you very much. I think that's, and I'll just share my concern with Dr. Titus. Maybe you can tell me how, once we have more kids diagnosed earlier, and I speak with a 11-year-old autistic granddaughter that is completely nonverbal. So this is a very personal issue for me. And anything I can do to get early diagnosis and treatment for my beautiful granddaughter, Luca, that I hope one day we find some beneficial treatments and cures for her, that she can live a productive and beautiful life. So I'm very sensitive to what's going on here today. But just tell me how we're going to access more care in a state that has such a void, if you will, of qualified professionals to deliver the service.
Julie Beasley for the record. We work this every day. And what we're really talking about, our kids are already here on the autism spectrum in Nevada. They're here. They're in our schools. They're in our early intervention programs. They're in the pediatrician's office. They're in families who aren't sure what to do with. What we're asking is to be able to do that earlier diagnosis. We should be diagnosing under 3, under 2, quite frankly, and into early intervention so that we have a better shot of outcome. We know that the outcome changes the earlier we understand it, diagnose it, and get it going. So they're already here. Professionals are being hampered by the way that they're told in this prescriptive language on how to do their scope of practice. And that's what we're really addressing. There is likely more to do, but this was our first step. Starting this, revisiting this language and bill.
So, Dr. Gaspard, for the record, Senator Stone, agree completely. This is step one of a larger process because we can move the numbers from one part of the equation to the other. But to try to address the the therapy provider shortages, that's certainly another topic, and equally as important is this one. Agreed.
Thank you. I appreciate you being here.
Thank you, Senator Stone, and thank you for sharing that story. I have a question. I don't see any others from the committee. I have a question. Can you talk a little bit about what we can gain or what we are losing? It depends on your perspective, right? By not having this in place so that children can be identified and diagnosed early.
Yeah, Dr. Gaspard, for the record. So I think there's two things. So one is the opportunity to get into treatment earlier, which leads to better outcomes, which of course the barrier is, do we have enough providers to do that, right? But that's one. The second, Dr. Beasley alluded to earlier, is it provides families with answers, right, and understanding. And it provides them with opportunities to access information with a specific diagnosis that they can then begin to better understand their child and better provide behavioral strategies at home or seek supports in the community that are outside of a therapeutic environment, parent support groups, online groups. I mean, there's some great things available to families as they are waiting to start interventions, and just simply knowing what's happening can reduce parental stress tremendously.
Thank you, Dr. Gaspard. Any other questions from the committee? Okay, seeing none, Senator will excuse you and the doctors to sit back for a moment, and we will open up the opportunity for people to come and testify in support. I will say that we're going to limit support testimony, opposition testimony, and neutral testimony to 15 minutes. We're going to limit it to 15 minutes, so a good old ditto works too, when appropriate. We'll start here in Carson City. If there's anyone there in Las Vegas who would like to testify in support of Senate Bill 257, please come forward to the table at this time. And before you speak, remember to say your name and spell your last name for the record. Please go ahead.
Good afternoon. My name is Abby Bernhardt, Bernhardt. I am with the National Alliance on Mental Illness. I am also a social work student at Walden University. At 10 years old, I was diagnosed under the autism spectrum. I've been in therapy since I was 3. Through therapy, I learned how to cope with being in large gatherings and how to effectively communicate without being too blunt or forward. I no longer fall under the autism spectrum, but I am considered neurodivergent as I have Irlen syndrome and I also have bipolar disorder. I understand how firsthand resources and support can help. Please support this bill. Thank you.
Thank you, Ms. Bernhardt. Please go ahead.
Vice Chair Taylor, members of the committee, Jonathan Norman, NORMAN, Nevada Coalition of Legal Service Providers. At any given time, we're representing about 3,000 kids in foster care between Washoe and Clark County and some of the rural communities. I was a CAP attorney in Clark County, and I can tell you these kids are in our foster care system without the appropriate diagnosis to receive care. And so, when you have, and not being able to access the appropriate diagnosis falls on people in poverty more than it falls on everyone else because it's hard to follow through with all those things. So I had a kid who was 16 on my caseload, and he did not have the appropriate diagnosis, although his parents legitimately thought he had the right diagnosis for services. So when I got him, it was one of my first cases. I was like, okay, let's start ABA therapy and these interventions. And I was told he didn't have the right diagnosis, and he went to the bottom of a wait list. So he was 16, unable to take care of basic hygiene, in desperate need of this. And so we got him on a wait list. And I think it was actually the Ackerman Center that expedited his diagnosis that allowed insurance to pay. And within a year, he went from not being able to take care of basic hygiene to taking care of that, having a chore. He took out the garbage at his grandma's house where he was living, and he was able to go to the store and buy a soda on his own, right? So huge steps, and that's the difference that having these services available and making sure that kids and families, especially in poverty in the middle class, are able to access these diagnoses, especially with their primary care physicians. So I urge your support. I want to thank the sponsor and the Ackerman Center for pushing this bill. Thank you.
Thank you, Mr. Norman. Please go ahead.
Good afternoon, Madam Vice Chair, members of the committee. For the record, my name is Andrew McKay, M-A-C-K-A-Y. I'm the Executive Director of the Nevada Franchise Auto Dealers Association. The committee's probably wondering, what in the heck is the car guy doing up at the rostrum with respect to an autism bill? Simply put, this is a cause that is near and dear to my members' hearts. And that's not being hyperbolic in the slightest. Many of our members, our board members and their spouses, are extremely active in the Ackerman Center. The Ackerman Center is obviously the brainchild that Gary Ackerman is on our board of directors. And my board had a very clear dictate that we will do anything we can to support this bill. Obviously, they covered the bill in due course and extensively, but I think it's important to put it on the record that it provides another arrow in our quiver to evaluate and treat autism spectrum disorders. As previously stated, it'll provide or improve access to care by those that need it most. And I emphasize that again, those that need it most. And further to dovetail off of the comments with respect to insurance diagnosis, that's going to bring treatment to folks' doorsteps, and the ability to get in front of literally the miracle workers at the Ackerman Center and other providers that can do this and hopefully treat the folks that are dealing with autism spectrum disorders. In short, obviously, our position is simple. This is a wonderful bill. I think demonstrative of the fact how good of a bill is that we're at the table with legal aid in full-throated support, Mr. Norman. So just want to make sure that we put on the record that we thank Senator Dondero Loop for her efforts on this bill and for sponsoring it and for the committee's consideration, and we strongly urge your support. Thank you, Madam Chair.
Thank you, Mr. McKay. Please go ahead.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Mary Brzezinski, here representing Nevada Association of School Superintendents, and we're supporting this bill because early diagnosis, whether there are professionals who can really do the deep dive with the young people who suffer from autism, it will help us in the schools to understand the child that we're working with better if we know their diagnosis with autism. And we have a lot of students with this, but that's why we're supporting this bill. The early diagnosis is very appealing to our school districts. Thank you very much.
Thank you so much. Rest before you go, we're going to go to Las Vegas and then come back here to Reno after we check the phone. In Las Vegas, we're going to take 4 down there. If we have 4 people who would like to testify in support of Senate Bill 257. So please go right ahead when you're ready. Remember, you have 2 minutes.
Okay, go ahead. Hello, I am grateful to be here to support SB 257. For the record, my name is Jan Crandy, C-R-A-N-D-Y. I am a former chair of the Autism Commission, and I was here in 2009 helping to pass the legislation that we're trying to change now. I fully support the changes that are happening. I am also a parent of an independent adult with autism. My daughter was lucky to receive a diagnosis before she was 2 years old and started treatment before she turned 3. It breaks my heart to know that children in Nevada are still having to wait for a diagnosis, some longer than a year right now. And that's not what we intended when we did this original legislation for kids to have to wait. We wanted them to get treatment as early as possible. This is a barrier to treatment access, which I do believe, and I know for a fact it's a factor in a child's outcome. This bill will remedy the diagnosis wait time and allow all qualified professionals' diagnosis to be accepted by insurance. When a child goes to a neurologist, which neurologists see autism every day, they know autism. And for an insurance not to accept a diagnosis from a neurologist, this should remedy the issues that we're having. I want to thank you, Senator Dondero Loop, for recognizing this barrier and sponsoring this bill. Thank you very much.
Thank you, Ms. Crandy. Let's go ahead to whoever's next in Vegas. Please go ahead.
Good afternoon. CYRUSHOJJATY. I am here to support this bill, and thank you for the state senator for sponsoring it. Yield.
Thank you so much. It's almost a ditto.
Good afternoon. Eric Lovas, for the record, LOVAAS. I'm president of Lovas Center here in Las Vegas, president of Lovas Center in Madrid, Spain, as well as founder of Fundación Eric Lovas para Autismo in Spain as well. I've been serving Nevada's children for 29 years and in the treatment field for well over 30. I was there when I had the honor of meeting Miss Crandy, as I was her daughter's first consultant. And I can say that getting children served back then was far easier than it is today. And I feel is directly related to funding. The more funding that's been available, the more barriers have been in place, including the need for systematic diagnosis. And I've worked closely with Dr. Gaspar and Dr. Beasley and fully support their efforts. And as draftees of this bill, I couldn't think of anybody more qualified to present it. So thank you for your work, and definitely the community supports 257. Thank you.
Thank you, Mr. Lovax. Is there anyone else in Las Vegas who would like to testify in support of Senate Bill 257? Please come forward. Okay, seeing a chair. And seeing all the chairs, okay, no one else is coming forward. Thank you so much. AVS, do we have anyone on the phone line?
If you'd like to testify in support on SB 257, please press star 9 on your phone to take your place in the queue.
Hi, thank you, Chair and members of the committee. My name is Leanne McAllister, McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics, or AAP. The AAP supports and encourages pediatricians to play a role in diagnosing autism in primary care settings. Autism diagnosis by primary care pediatricians is tailored to identify, assess, differentiate, and diagnose young children in 1 to 2 hour visits. The majority of primary care pediatrician autism assessments being evaluated follow best practices, including structured behavioral observation, comprehensive history, and integration of clinical expertise. In addition, PCPs have continuity with families and understand the developmental trajectory of children under their care, as well as the strengths and challenges within the child's family and community. They also may be knowledgeable about local and culturally congruent supports and services. What's most important, though, there is evidence of high family and pediatrician satisfaction with autism diagnosis in primary care. Fellows of the American Academy of Pediatrics are the most extensively educated providers of pediatric care and have the ability to manage, coordinate, and supervise the entire spectrum of healthcare, from a diagnosis through all stages of treatment and in all practice settings, including diagnosing autism spectrum disorder. We stand in strong support of SB 257. Thank you.
Thank you, Ms. McAllister. AVS, another caller?
Yes, Chair, one moment.
Good afternoon. My name is Dr. Glenn Johnson, Johnson for the record. I own Accelerated Learning Clinic and Accelerated Learning Academy. We are a private school as well as a clinic providing ABA services to individuals 2 to 15 years of age in Las Vegas. I'm in full support of SB 257. First, it provides more access to families, allowing healthcare providers the clinical decision to administer a brief or comprehensive assessment to screen and assess for formal autism diagnosis. Treatment for autism funded by health insurance may not begin until a formal diagnosis is obtained. The current protocol requiring a comprehensive assessment for each individual leads to long wait lists for diagnosis. This is delaying families and their children from beginning early intervention treatment, demonstrated to have the best long-term outcomes, sometimes by 6 to 12 months. This is a critical loss to Nevada's children and youth with autism. Second, the language clarifies and are more reflective of what is already occurring related to the development and implementation of treatment plans. Clarifying and updating these rules benefits professionals and consumers alike to ensure that each professional is acting within the scope of their own practice. Lastly, updating these rules and clarifications for insurance carriers benefits families and professionals alike. Often as a treatment provider, we are getting denials to authorization requests for services, stating a pediatrician screening and assessment is not enough. The requirement is a comprehensive diagnosis. This bill will help ensure that those practicing in their scope have the educational training and clinical judgment to determine what testing is sufficient and not leaving a medical decision in the hands of insurance policymakers. The passage of SB 257 will allow a greater number of individuals access to diagnosis sooner, which in turn will allow earlier access to intervention. Again, I wholly support the passage of this bill, and I thank the committee for their time and support on this. Thank you.
Thank you, Ms. Johnson. Do we have another caller, AVS?
Yes, Chair, we have one more caller.
Hello and good afternoon, Vice Chair Taylor and the rest of the committee. My name is Damon Schilling, Schilling, and I'm the Director of Government Relations for Intermountain Health here in Nevada. After hearing the great presentation and the previous testimony, we just want to say ditto on this bill. Thank you.
Thank you, Mr. Schilling. Okay, we'll come back here to anyone else in Carson City who would like to make public comment, please, testify in support, please come forward at this time. Go right ahead. Yes, so we'll share this. Okay.
Thank you, Chair. Or thank you, Vice Chair Taylor and members of the committee. Joanna Tiveros with Cara, Nevada, on behalf of Touro University. We are proud of the incredible work that we do for the Pierce Autism Center at Touro, and we are in support of SB 257.
Thank you so much. Please go ahead.
Hello, my name is Carissa Pierce, CARISSA, and I am with the Children's Advocacy Alliance, and we will just say ditto to all the amazing testimony that has been heard. We are in strong support of this bill. Thank you.
Thank you, Ms. Pierce. Is there anyone else in Las Vegas? Okay, seeing none, is there anyone else on the phone line? Because our 15 minutes are
If
up.
you've recently joined the call and would like to testify in support on SB 257, please press star 9 on your phone to take your place in the queue. Chair, there are no more callers in support.
Thank you so much, AVS. Is there anyone here who would like to testify in opposition? In opposition, please come forward at this time. If you're in Las Vegas and you'd like to testify in opposition, please do the same. Go ahead when you're ready.
Thank you, Vice Chair. For the record, my name is Spencer Flanders. I am with Tri-Strategies, and today I'm representing the Nevada Psychological Association, and we're in opposition to this bill. First, we want to recognize the statements from the support testimony. Mental health is an issue inside the state of Nevada, and we have similar goals in that way, but we have some issues with this bill, specifically looking at Section 3, which removes the protocols for autism, especially for those under the age of 21. It eliminates the assessment for cognitive function, language functions, and adaptive functions, which are all crucial components when we're looking at the diagnosis process. Additionally, this bill allows individuals with lower level licenses to conduct complex diagnoses, which can have life-altering consequences for those who are misdiagnosed. We also have some, Without the assessments of cognitive function, language function, and adaptive function, it calls into the validity of the ASD assessments. Again, once we realize that this is a major issue, but this bill needs some adjustments in order to make it viable. Thank you.
Thank you, Mr. Flanders. Is there anyone else here in Carson City in opposition? Seeing none in Las Vegas. Is there anyone in opposition to Senate Bill 257? Okay, seeing none. AVS, we'll go to the phone lines.
To testify in opposition on SB 257, please press star 9 on your phone to take your place in the queue. Caller with the last 3 digits, 678, please press star 6 to unmute yourself.
Good afternoon. My name is Jessica Garrett. That's Garrett. I am a speech language pathologist, and I wholeheartedly appreciate and support efforts to expand access to care and commend the commitment to addressing long wait lists and provider shortages. Ensuring that individuals receive timely evaluations and services is essential, and I fully support initiatives that prioritize high-quality, patient-centered care while upholding best practices. I do come to you with concerns today regarding the vague language of the bill. While the bill states that providers can diagnose autism if it falls within their scope of practice, my concern is that scope of practice laws under the NRS can be updated over time. And this could create a dangerous loophole that could allow more unqualified providers to assess and diagnose autism in the future. The vague term provider of health care is highly problematic because it does lack clear guidelines on who is actually qualified to diagnose autism. And without specific training requirements, this could allow a wide range of unqualified professionals to assess and diagnose autism, increasing misdiagnosis and inappropriate treatment plans. Dr. Beasley did mention specific providers that would be qualified and able to diagnose autism. I believe it would be crucial to add that more specific language into this bill regarding qualifications and, of course, the assessment standards. An autism diagnosis requires rigorous training, credentialing, and expertise in neurodevelopmental disorders and differential diagnosis. Licensed professionals qualified to diagnose autism are uniquely equipped to distinguish autism from other conditions such as ADHD, intellectual disabilities, language disorder, and sensory processing challenges. I also want to talk about that SB 257 highlights a broader issue that all children with developmental, cognitive, or communication challenges deserve access to high-quality, evidence-based care regardless of diagnosis. Current policies limit access to services for children with other developmental disabilities. If the goal is to improve access to care, efforts should focus on expanding services and insurance coverage for all children in need rather than lowering diagnostic standards. We recognize that there is a provider shortage and long wait lists. However, sacrificing diagnostic accuracy is not the solution.
Doctor, I'm sorry. Doctor,
I'm
going to interrupt you here. Your 2 minutes are up. Will you please wrap it up so we'll continue on. If you have other comments, you can send, that's okay. You can send your written comments into the secretary and we'll all get them. Go ahead. Please wrap up.
Okay. Perfect. Instead, Nevada should focus on ensuring all children receive the care they need regardless of their diagnosis and increasing access to providers for services. I urge lawmakers to amend SB 257 and advocate for policies that prioritize diagnostic integrity while ensuring equitable access to high-quality care.
Thank you,
for all children
Doctor.
in need.
Thank you so much. We appreciate the call. Is there another caller, AVS?
Yes, Chair, there's one more caller.
Thank you so much. Is there anyone here who would like to testify neutral? Oh, there's another caller? Oh, I'm sorry. Please go ahead, caller.
Thank you. No problem. Good afternoon. Anna Binder, ANNABINDER. I would really like to ditto that last opposition, and then I'll just summarize that this bill, Senate Bill 257, appears to prioritize cost-cutting and administrative streamlining over the quality of care for individuals with autism spectrum disorders. The existing regulations are designed to protect vulnerable populations and ensure that they receive the best possible support. By removing these safeguards, we risk undermining the process made in autism care and support. And I've submitted the rest of my public comment in written format. So thank you so much.
Thank you, Ms. Bender. Any more callers, AVS? Let me be sure.
There are no more callers in opposition.
Okay, thank you so much. Now we'll turn to neutral. Any neutral testimony here in Carson City? If so, please come forward. If there's neutral testimony in Las Vegas, please come forward as well. Please go ahead when you're ready.
Thank you, Madam Vice Chair, members of the committee. For the record, Adam Plain, Plain, with the Nevada Division of Insurance. We're neutral on the bill. We haven't had a chance to appear before this committee this session, so just want to say as a general rule of applicability, we're neutral on most items. We opine they're neither good nor bad. We just want to provide information to the legislative body for your deliberation process. I did submit written testimony on this matter, including 2 pieces of supplementary information regarding a process known as federal defrayal. I submitted it in both narrative and PowerPoint format, so people can choose to learn how they prefer. In regards to Senate Bill 257, the division wanted to make it clear on the record that as currently written, the division has evaluated Senate Bill 257 as not triggering federal defrayal provisions. We wanted a clear legislative record as this goes forward, so that way if it does change, we can reevaluate at that time. If there's any questions, I'd be happy to answer. Thank you.
Thank you, Mr. Plain. Seeing no one else here for neutral testimony in Carson City and no one has come forward in Las Vegas, AVS, is there anyone on the phone lines with neutral testimony?
Testifying neutral on SB 257, please press star 9 on your phone to take your place in the queue. Vice Chair, there are no callers neutral at this time.
Thank you so much, and thank you, Vice Chair, for chairing while I was presenting. Does our bill presenter have any closing remarks?
Thank you very much, Marilyn Dondero Loop. For the record, thank you to the chair and the vice chair and the committee members for hearing this bill. It's a really important issue that I continue to work on. I urge your support, and I always say when you have vulnerable children, nothing ventured is nothing gained. So I always feel like taking a step is always a step in the right direction for our children. So thank you very much, and Senator, you got here just in time, so thank you.
Thank you so much, and thank you for joining us. Next, we're going to go ahead and move on to the hearing on Senate Bill 250. This bill revises provisions relating to healthcare records.
We don't have enough time. It's 4:23. We have to be downstairs. It's 4:45.
Never mind. We are having to go downstairs for a speech from Senator Cortez Masto.
We could do a presentation and then we can come back after.
So we're going to do the presentation right now for, Senate Bill 250. This bill revises provisions relating to healthcare records. We're going to try our best to squeeze as much as we can for the presentation, knowing that committee members may have to take their questions after the bill presentation, and then we might have to do testimony by the time we return. So at this time, I'm going to go ahead and open the bill hearing and invite our bill sponsor, Senator Lang, to present when she's ready. And if there's any bill presenters also in Las Vegas, if you can please come forward as well.
Thank you, Chair Donate. I'm Roberta Lang, representing Senate District 7 in Clark County. Thank you for the opportunity to present Senate Bill 250, which shifts control of medical records from providers to patients, enhances privacy protections, and simplifies record access to considering small healthcare provider limitations. My co-presenters today are in Las Vegas, Paul Bamfer, Shrey Kapoor, and Tom Zontobel. Paul will do slides 1 to 7. Shrey will do slides 8 to 13, and Tom will do slide 14, and then kick it over to Paul, and we'll go back to Tom. And then I will go through the sections of the bill, and we also have an amendment. So if we can go to Paul.
Thank you, Senator Lang. So I'm Paul Banford. My last name's spelled B as in boy, A-N, F as in Frank, E-R. I am employed by EISC Lab Data Automation. We've been automating laboratories for 20 years. And part of my presentation today is focused on standardization and the importance of the electronic health record patient ownership. So one of the things is I wanted to thank you first for allowing us to present this transformative vision for electronic health records under Senate Bill 250. We commend your bold initiative to championing the patient ownership of EHRs. This legislation ensures that health records follow patients seamlessly, enabling real-time, structured, and automated health data for both patients and providers. Today, we will discuss how technology can make this a reality. And then the presentation, do you actually see that somewhere? We're on slide 3.
In the interest of time, I think you could just proceed with your remarks, please.
Okay. So one of the things that I'll be covering is the standardization and automating of EHRs for real-time structured healthcare data. 2 other gentlemen will be presenting as well, and they'll announce themselves when they come up. One is Shrey Kapoor, and he'll spell his name then. He's going to be talking about enhancing patient and provider communication through automated EHRs. And then Tom Zumtbo, he's going to be talking about the broad benefits of EHRs for patients, providers, payers, and healthcare systems. We will cover the importance of patient-owned EHRs, challenges and solutions to EHR interoperability, use cases demonstrating real-time data exchange, benefits for stakeholders across healthcare and R&D. With that, is there any chance we can get the presentation up? Because they're definitely...
Please proceed. Well, the members have the slides already, so just please proceed with the presentation.
Okay, very good. The foundation of effective EHRs lies in biomarker measurements, biological indicators that provide critical insights into a patient's health and performance. These biomarkers collected through advanced healthcare instrumentation. The EHR is the backbone of modern medicine. Senate Bill 250 establishes patient ownership of EHRs, ensuring patients have full access to their health records, consistency in data across providers, real-time medical decision-making based on structured and unstructured data, automation of health data collection, improving efficiency, and reducing administrative burdens. By empowering patients with ownership of their data and ensuring providers have instant access to high-quality, standardized health records, we can revolutionize healthcare in Nevada. Despite the benefits of EHRs, challenges remain due to fragmented data systems and manual record keeping, causing delays and inefficiencies. Key issues include inconsistent data. Records exist in different formats, creating redundancy and inaccuracies. Delayed access. Providers struggle to obtain timely patient data, impacting diagnosis and treatment. Manual processes. Time-consuming data entry diverts focus from patient care. Limited automation. Many diagnostic tools lack direct EHR integration, leading to incomplete records. To solve these challenges, science-based industries use structured electronic data exchanges, ensuring instrument-generated results integrate seamlessly into provider workflows. The same approach can create a real-time standardized EHR system, eliminating inefficiencies and improving care. To address these issues, we would standardize EHR communication, ensuring all providers receive the same health data, but in the order of need based on their expertise. Automate the structured instrumentation whenever possible. Structured electronic instrumentation should directly feed into EHRs to eliminate manual input or curation errors. Aligning expert assessments with measurements, combining structured diagnostic data with unstructured expert insights for comprehensive decision-making. Implementing standardized, structured, real-time EHRs provides numerous benefits across the entire healthcare ecosystem. For patients, ownership and control over their health records, improved accuracy, reducing redundant testing, faster, more informed healthcare decisions. For providers, seamless access to structured patient data, increased efficiency, reducing administrative workload, enhanced decision-making through real-time analytics. For payers and insurers, lower costs by eliminating inefficiencies and redundant claims, improved fraud detection and prevention, a strong foundation for value-based care models. For the state of Nevada, strengthened public health monitoring and response, improved healthcare system efficiency and resource allocation, a competitive advantage in attracting biotech and healthcare innovation. Now let's discuss how patient data flows seamlessly from one provider to another, improving efficiency and continuity of care. For this, I will hand it over to Shrey Kapoor.
Thank you, Paul. My name is Shrey Kapoor, S-H-R-E-Y, last name K-A-P-O-O-R. I'm the founder and CEO of MedSeco. To give a little background on myself behind this testimony as well, I was in medical school at Johns Hopkins, and during the pandemic when I lost my grandmother, and it was a tough time being the only person in my entire family taking ownership of her care. But what really was the difficult part was the fragmented healthcare ecosystem that exists today, that going from one provider to another, we did not feel as a family empowered with the right tools, with the right data, with the right ability to go from one provider to the next. And the sharing of this information that burden was placed on the family and their caregivers. After that, I launched significant initiatives, led around 50 medical schools across the country, raised a ton of capital, and built rapid antigen testing programs to deliver tests at the site of care. But ultimately, what I learned was that we need to work together as a community to empower our patients. I know we're doing this here in the Senate building, but it doesn't seem like a political issue to me to empower patient care. And that's where I come from. I'm building a technology solution to aggregate data across medical records so that patients don't have to fill their medication histories, their labs, their imaging are all together in one spot for whether it's payer groups or disparate health systems in particular. But I think there needs to be some federal oversight and state oversight and county oversight and all of these initiatives so that the folks that are so disparate actually are incentivized and compelled to work together. Because only when we work together will we be able to deliver the care that our patients deserve. There are multiple examples and benefits to this of a structured real-time electronic health record that is in the hands of patients. Better coordination, faster interventions, patient empowerment, improved outcomes, long-term care continuity. But I think those benefits are obvious. I think some of the more exciting things that I think we all need to look at as a community is when we aggregate data that is separate and siloed, that allows us to understand it and analyze it and do better for our community. So that's where the public health initiatives come in. We can understand which communities are at higher risk, which patient populations are doing worse, and ultimately unlock what are novel AI tools and integrate and implement them.
Thank you, Shrey.
This model.
If you can take a pause, we do have to go downstairs. Just mark where you left off your remarks, and then we can continue. We're going to go into recess until the call of the chair.
Thanks, Fabian. Senator Dante, sorry.
Welcome everyone back to Senate Health and Human Services. We're going to go ahead and begin. So if our presenters can come to the table, and we will continue where you left off on your remarks.
Hi, Senators. We are back. Shrey Kapoor had to leave. He had to catch a flight. And so if you're ready, I can pick up where we left off just and briefly summarize what my section of the presentation was.
Please proceed.
Okay. Excellent. So I'm assuming you see the slides. I have it on my computer, right? Okay. And let me just move along here and spacebar, right? Yeah, it's not moving. Arrow? Okay, great. So, this is where I started to turn it over to Shrey. If I just summarize briefly, what I was trying to get to is the standardize the electronic health record for all providers and also all payers and patients. I'm going to move on from this, but the critical part is that I think that what we have with the patients, this is where Shrey was going to take over, is they're really lost in their health journey, and because of the electronic health record. And in other cases too, when you don't have an emergency, do you actually remember what office visit you had or what medical person that you did have? So this particular slide here, it actually has a patient journey. And the concept is to actually start tracking that in a standardized manner and actually have that be available to all providers that this person would potentially see. And to build that out, though, one of the things that we see in other industries when we do have exchanges is that we push it through the instrument companies. And so they have those formats. That's what talks to Epic and Oracle and so forth with Cerner. And when you have the instrument companies actually pushing the data in the format, then it feeds into these electronic health record systems. And then you query the information management systems of the practices, and you can do that, anything that's electronic these days. And you query that and you bring in this unstructured data. And so in doing so, I think one of the biggest things with the patient ownership that you're with the bill is to establish that as the beginning. And from that, we can then start discussing how can we make it so we can actually track the patient's journey. And that's for themselves. And from there, to be able to communicate that journey anytime in a medical provider needs to look at those records. And so the reason why I'm here to present is, and take Shrey's part here, is that there, in some cases with certain providers, certain payers and groups like the Teachers Health Trust with Tom, is that that's what their focus is on right now. And you don't really have to break that structure, but we have to come to a consensus as a community as for what that structure will be so we can communicate amongst the different systems. So when you're outside of the network and so forth, that you can push that electronic health record to that specific medical provider and they can see your history. In addition, some of the apps that you can build off of that, which is very critical, is that you can start having those apps fill out forms, for instance, and also the patient history to actually pre-populate those forms so you don't have to manually write those forms or actually type them into a form that's generated electronically, to where you could have your electronic health record, update your allergies and so forth. And in addition, when you actually don't want other providers to see your electronic health record because it would give a different perspective such as mental health, that you could actually not provide that to a referral if they have nothing to do with that. So to actually have these, the first part is having the patient ownership to be able to then take that record and use it for referrals and have it basically theirs. Now, I understand that with providers today, when, it's a lot of work to get there, and if we can reverse the script and actually go towards where we can provide electronics through the big instrument companies that provide these instruments, that we can populate a baseline EHR that then can be used as tools for the enhancement of the assessment that the provider provides. So with the slides that you have, it goes through the different scenarios just as an example. And one of them is the actual EHR for a female during maternity and a high-risk pregnancy. And then the second one goes into a male and being out of network and on travel. With that, you see that the actual benefits, for instance, on the male is that the continuity of care being outside of network, the improved outcomes, the reduced costs, and then the patient empowerment. With AI and machine learning, Shrey had put this into the presentation. And one of the things, if you don't have a good baseline with an electronic health record, the problem with AI machine learning, it's going to take you as far away from the right answer as possible, especially when you don't have all the information. And so this becomes really critical for the electronic health record and the way we're headed today in society. And so, Shrey was going to talk about how it benefits at this point without a consolidated EHR or even the patient owning the EHR and providing it to the referral. AI machine learning is not going to benefit them because it's not going to be as exacting as it needs to be. With patient ownership, for the providers, the benefits are enhanced care coordination, real-time access to data, improved diagnosis and treatment, reduction in administration burden, so especially if you automate the instrumentation and then allow the assessment from their information management systems to be attached, and then the personalization of care plans. From here, I'm going to turn it over to Tom.
Good evening, Senators. Thank you for letting me speak to you this evening. My name is Tom Zumtobel, Z-U-M-T-O-B-E-L, and I'm the CEO of Teachers Health Trust. What brought me here to this point is really the fact that an experience that I've had in all my years of healthcare. I was at the Culinary Health Fund as the president of Culinary Health Fund, and our vice president of managed care was a nurse, and she had all the relationships that anybody would have if you were the vice president of managed care for this in this market. So she knew almost every doctor, great relationship, and she had a abnormal mammogram, and it took 16 weeks from that abnormal diagnosis to her first treatment, so 4 months. And it kind of shocked us, right? It was hard and shocking. And then we ran our data, and we had the same experience with all of our membership. It was on average 16 weeks from abnormal mammogram to first breast cancer treatment, which we thought was just wrong. And then I came back to the Teachers Health Trust just 4 years ago, and 10 years have passed. And one of the first things that I did was run my data to see just how much the market has changed. Coincidentally, it was the same, right? The same experience. It was 4 months from diagnosis to first treatment. And that's not because there's managed care rules in the way for cancer treatment. All the authorizations were lifted. And it's not because we didn't have access, because she knew all the doctors. She could get in, she can get an appointment, we can get access. The challenge is the communication between the providers' offices. And they would, order, they'd have the mammo boss, somebody ordered a biopsy, the biopsy had to get ordered, it'd have to get read, the information had to get back to the provider that ordered it, they'd have to get back to the treating provider. Those things just take time, and the system is just truly, truly broken. And so what we've tried to do at the Teachers Health Trust, since I've been there right away, we developed what we called a health investment network. And it's a lot of the programs that we've talked about through coordination throughout this afternoon. But mostly what we did is we pay the doctors more money to be engaged, which is important, right? And then we also, part of that engagement includes them showing up at our meetings every month and talking to us about how we can work together to improve healthcare delivery. Instead of us making decisions how to improve healthcare delivery, how do we work together with the providers to improve healthcare delivery? So in one of these early meetings, one of our referral specialists brought in a stack of CDs, and he brought in a stack of paper. He goes, do you understand what we deal with in the market? He goes, these CDs are images. So we ask our patients to bring in their medical imaging, and they'll go to the imaging provider. Lots of times the provider will give them a CD, and they'll show up at our office with a CD. And we don't have the software to run that CD. We don't have the software to read that CD. So we send them out oftentimes just to go get the imaging repeated, right? And then with the medical records, lots of times the members the patient does everything they need to do to request the medical records, but the paper medical record shows up long after the care has been provided, right? Long after the patient was there, the medical record shows up. And so the physician said the best thing that you could do is help us to get this information in front of us real time, data that's useful and available to providers when the patient is in the office. So that's when we endeavored with MedSet Go to start to do that. And what we've been able to do is network 12 different electronic medical records in the Las Vegas market with about 40 locations of physicians and probably about 120 physicians, but about 40 tax IDs. And now they're sharing that information real time. And we're doing it also with Steinberg Diagnostic and Quest Diagnostic. And what we're doing is getting the information in the hands of the physician. But what's missing is we don't have that information clearly in the hands of the member. Because the member, if they own that medical record, it starts to get to us to the point where we have both, they can hold their doctor accountable, right? And not in a bad way, but in a partnership way where they both know the care plan, they know the information, it's understandable, and they work on that information together. And it's critically important to us that we work on the system and get to a point where we have accountability for the doctor, for the health plan, and for the member. And that's what we really believe. If the patient owns the medical record, that's a critical step for us to see that starts to happen. Because right now it seems unheard of that sometimes doctors don't think that the patient owns their own medical record, and we have to empower the patient, and then with empowerment will come accountability for both the patient and the doctor. So thank you.
Okay, Senator Lang for the record. With that, Chair, I would like to go through a teeny bit of background information, go through the sections of the bill, and also the amendment. And I'm going to try and incorporate the amendment in the sections of the bill in the interest of time. Currently, medical records are considered the property of healthcare providers rather than the patient. This can make access to records difficult and lead to disputes over control and delay of treatment. There have been concerns about third parties such as insurers, employers, and unauthorized medical personnel gaining access to patient data without consent. Patients often must request medical records from multiple healthcare providers, leading to delays and inefficiencies in medical treatment. Senate Bill 250 aims to address these barriers and establishes patient ownership of medical records, giving individuals legal rights over their healthcare information. The bill also, with that, Chair, I'll briefly walk you through the sections of the bill. I was just going to say something that we've changed. And so in Section 2, we have removed Section 2 in its entirety. In Section 3, we've removed the word electronic from Section 3 so that all health records are the property of the patient, not just in electronic form. And in Section 4, we removed the establishment of a statewide electronic health repository and instead requires the director of DHHS to make certain actions related to information retainment. We also added Section 19, which requires the Director of the Department of Health and Human Services shall submit a quarterly report to the Senate Interim Health and Human Services Committee detailing the progress made toward implementing the provisions of this act. So with that, I stand ready for questions.
Thank you so much. Committee members, any questions? Senator Titus.
So thank you, Senator Lang, for bringing this forward. I have frequently found that it's very difficult to access patients' information. They come in and they had an x-ray and they had it last week and I can't get it on my electronic medical records. And so I need to know, and so order another x-ray, those kind of things. And so I appreciate what you're trying to do. When we were mandated to have and go to electronic medical records many years ago, those electronic medical records weren't mandated to talk to each other. So now we have all these different systems and all these medical providers. I'm concerned about this bill and how do we as a provider, because these things are very expensive, create the communications that, okay, the patient comes in, now they want their electronic medical record. Do I download it then onto a disk and a flash drive, and then it sends to them, and then does that then have to be able to be uploaded on the next provider that I go to? And what if they don't communicate, or you have that form in the old CDs when it came to X-rays patients would bring me, I frequently couldn't download them. And so I'm just worried about that communication level and the potential cost to providers.
Thank you, Senator Titus. I think the people in the South will have something to say about that. But as you know, Senator Lang for the record, as you know, I see a lot of medical doctors for my kidney disease. And I talk to a lot of people in the doctor's offices. In the last one I went to was a new doctor, and I had to fill out a 30-page biography about myself and my medical care, which I couldn't even remember what happened 50 years ago, right? And so I think the purpose of this bill, and we've put a lot of work into working with a lot of stakeholder people, and I'm not saying in this bill that we have the answers. I'm saying that we have work to do, and we have to start somewhere. And so, which is why we added the Section 19, where the Department of Health and Human Services, HHS, has to give quarterly reports to the interim committee about the progress that they have made working with, I hope, some of the same stakeholders that we've been working with, because what we have found is that people are at different paths along the way. Their journey is different, right? And so this isn't to say my way is the best way. I mean, I actually received lots of emails from people who were concerned that we would have a state repository where we'd store all these because it's personal to them and they don't want it out there. And so we have to figure out a different way that we can get these medical records. I mean, I kind of laugh and tease, and I think I might have said something to you, but I see a day when we have a QR code where we can go to the doctor and give them our QR code, and it'll populate the paperwork. But maybe in the South, if you have some input on this, that would be great.
So this is Paul Banfer again. one of the things that we're trying to do is make consistency across any one of the providers. And one of the things is to take existing information, informatics infrastructures from different services like the Teachers Health Trust, integrated with HIE as well, integrated with culinary, where we're leveraging each other's way of communicating the results from referral to referral, but then leveling out the baseline of information to get passed. So how you present it is fine. What we're looking about doing is establishing the different foundation for the different electronic health records that would be provided by the instrumentation and then the assessment as well. So for instance, imaging would go into an imaging database that could be available on all three parties, and with that they can establish their applications to communicate that to their referral group. If it became available, let's say you were outside a network and another provider needed to be used, then it could be accessed through the intranet within something which is both in Reno and Las Vegas, and that would be through Switch. So Switch would be your repository under internet kind of scenario of data transfer, and it would also be the foundation for these providers to talk to, which would have to be managed by someone within the state, and that would be, I would assume, would be part of the HHS. So when you do that, when you can actually do that, and let's say you, the patient, provided a way or consent to use that data as anonymous data, with research and development, the key issue there is now we can start doing predictive type medicines. We can do better diagnostics. We can do preventative medicine. Those kinds of things, if we can establish that structure and as a community come together on the structure and then work on the actual communication and use the instrument companies to provide that format, then what would happen is that it wouldn't be a cost of the provider. It's that the instrument company would want to do that, because originally HL7, which was the communication tool that you do with older type of provider networks, is, or if you see an Epic or Cerner, that HL7 was the format. Now it's Microsoft and it's FHIR. But in either case, if you have a 30-year-old system, that format's still the same. It's just it's providing the same type of data. That provides that consistency. So if we can capture that and actually have it on an internet based and then have it controlled in a manner that with the services that we have already, then it can communicate outward and the applications can be made by these provider networks. Yeah. So Tom.
Senator Lang, let me just do a really quick translation of that. So my example where I had the doctor receives the CD of multiple imaging, and then they don't have the capability to open or read it. So sometimes they're forced to do another test. What Paul has just described, the way that the data is going to be distributed to the doctors, it's consistent. We're going to eliminate the CD problem. So when it comes through, it comes from the instrument, so it's consistent. But most importantly, when the doctor does receive it, it'll be in their computer, in their medical record, so you don't have to go look for it in another place. It's not another jump drive. And so in addition to it being in the physician's office and available, it'll also be available to the patient, and the patient will have it on an app or in their possession, and they'll also be able to share it. But more importantly, it's in the doctor's record in a useful, consistent manner.
Thank you so much. I'm going to let Senator Titus ask a follow-up question, but I just want to be clear that the bill amendment no longer reflects the transfer of data. So we're not talking about that anymore. This is now the philosophical question is the ownership of the data. And so they're two different conversations, right? you have removed the repository in terms of how that coordinates between institutions. We're no longer talking about that. Now we're talking about how a patient can access it. So I just wanted to make sure that we're all on the same page. Senator Titus.
Right, thank you, because that whole repository question was a big issue for many of my constituents and myself who, if the patient owns the data and they have it, for example, Senator Lang, I agree, when we have our healthcare records, I have it on my phone. I have my last lab test and all those. It's an app. It's on my phone. I can easily give that. But I think it's really important if we could develop an app, frankly, that you could go into your provider and upload all of your, I live at this address. These are the things I have, and that you share it with your own phone and your own app. I mean, I think most people would want to do that because you have it in your possession. What I worry about is that broader span of, how do they communicate? Who owns it? How is it private? All of that. But I like the concept of sharing. You go in, you don't want to fill out that 30 page. You don't feel good. You want people to here's what I have. Here's my test. And now that I have it on my app on my phone. So I'm looking at something along those lines, are very appropriate as opposed to the repository. Yeah. So I'm glad. I'm telling folks and putting notes in it. It's been redone. There's no repository. So,
Vice Chair Taylor.
Thank you, Chair, and thank you, Senator, for bringing the bill. I just have a question. I think it's really important for patients to own their own medical records. My own experience with having breast cancer and seeing different providers and so on. It helped a lot because they could access my records. I had to bring a CD right back then, but they could get to it. But my question is, I also have an app, right? It's called My Chart, and I can right now open up and pull everything. Matter of fact, sometimes I get my test results like on my way to the car. I mean, it comes out just that fast. How is this different in terms of accessibility standpoint? Because I can access anything through that. How would this be different than that?
Paul or Tom?
Senator Lang, I'm happy to take that. Tom Zumtebel for the record. It's exactly the right place to go. That My Chart is the equivalent of what we're trying to create because you do have complete access. You have communication with your provider. It's fairly seamless. The problem with My Chart is it's only in any provider that has the Epic electronic health record. And so you must be up in Reno at Renown or you're down here with UMC, but there's only a handful of people in the state that use Epic. And so what we're doing is communicating all of the electronic medical records to the patient so the patient can control their entire medical record, even if they don't even if they're not lucky enough to be in the Epic system. Because what would happen to you is if you go outside of the Epic system, then that information would not be in your chart.
I see. But just about all of my providers, I get all of my information from all of my doctors, pretty much. Maybe if I see a specialist who's outside of Renown, perhaps, but I understand that if they aren't in Epic, then it wouldn't be. There wouldn't be. My orthopedic surgeon though is not in Renown, and I get those records. So anyway, thank you. I wanted to see the difference in that. Thank you.
Senator Lang for the record. I think it's very complicated because, so in my medical records, I have Quest, Mayo Clinic, My Chart, Village Medical, Now Clinic, My Health. So it would be great, I think, for patients if they could have that all in one place and they didn't have to remember passwords and figure out how to get into their personal medical records.
Thank you. Any other questions? Senator Sung.
So thank you, Senator, for bringing this idea forward. And, electronic communication of medical records is definitely the future for us. And I certainly understand in your situation where it's frustrating to duplicate so much medical information. And I'm happy to hear that the repository issue is gone because I had concerns about hacking and HIPAA and issues like that. But am I understanding this right, that is there still an effect on hospital-to-hospital communication? In other words, if somebody's at Renown and they're going to go to UMC, is there anything in the bill now that's requiring them to communicate, transfer a record? Not at all. There's no transferability at all. anymore. Okay, and then what about at the doctor's office? Are doctor's offices software going to have some type of a module that will allow a patient, and I fully support the patient owning their medical records, is there going to be something requiring them to adapting their software to ensuring that Jeff Stone can tap into his medical record into the doctor's office and download it? That's my record, I should be able to grab it.
Tom and Paul?
Yeah, that's the setting up. The most important thing is setting up the consistent formatting for the record to be downloaded into the app so the patient has control. We're not necessarily, I think your question's a little bit bigger. Are we mandating that every single provider in Nevada actually submit it? We had envisioned with THT, all of our network providers are obligated to submit it. And so that would be part of the relationship between the health plan and the provider, that they'd be obligated to populate the member's record.
And this is Paul Bamford. Consistency is going to be very critical to be able to communicate from system to system. And that's kind of what we're trying to, from the ownership bill to then from there to start talking about the structures to communicate from these different systems. So that way they're available from, for within network or outside of network, from provider to provider. And that way, the key critical part to that, though, is the relationship between the patient and the provider having all the information so they can make the right answers. Thank you.
Great, thank you so much. I'm gonna do my questions. I'm trying not to go in a rabbit hole because I know how complicated this issue is. So let's see how far I go, because I know we all want to go home. Okay, so first things first, I want to clear up some misinformation or anything so we're all on the same page. There's a difference between patients owning their data versus having access to their data. No federal law at this current day states that patients own their data. HIPAA pretty much establishes that patients have the right to access their data, okay? From my understanding, based on how we wrote AB 7 in the 2023 legislative session, there's only one state that has explicitly stated that patients own their data. But that's a philosophical question that opens a lot of can of worms, which is why we didn't include it as part of AB 7 last year. That doesn't mean that we can't do it, but it's just that let's just have the same playing ground that there are two different things. Owning your data is different from having access to your data. And so I guess the question becomes, right, the philosophical question that I'm trying to understand and wrap my head around is, if patients own their data, to what extent do they own their data? And I'm going to give you an example, maybe if you can answer for me. There is biometric data, right, that patients have access to. So, for example, your lab results come back or your genetic data comes back, right? That's one part. But there's also data in the medical record. For example, a physician may put, this patient is erratic. This patient suffers from drug addiction. We put that in the notes because it's helpful for the other providers when they come in, if the patient were to come back, so that we can provide a better level of care, of understanding of the patient. If the patient owns the data, does that put us in a position where the patient can say, I want the physician notes to be removed because that's not part of my treatment and I don't want that to be a part of it? Does this bill transferring the ownership of data now open us up for essentially putting providers in a place where cases where patients can refuse to share or critical health information because of treatment of care, as I explained? So how are we going to handle that situation if a patient decides to do that, or if they disagree with the diagnosis that the provider gave them?
Senator Tom Zumtebel, I'm happy to give that a try. That's a very big question for sure. But the way that we've thought about it, and you heard me say accountability in my presentation, and we're expecting to hold the physicians accountable. And you hold the physicians accountable by the member owning their data. It's not appropriate that a doctor, doesn't seem appropriate to me that a doctor who's treating a patient wouldn't fully disclose everything that they're telling that patient or writing about that patient, because you can't It's not whole health if you have secrets from, or if you have information you're not sharing. I know a lot of people would disagree with me, but I just don't believe that this is about transparency, and this is about the member knowing what the doctor is saying about them and what the doctor is treating and being on the exact same page. And I think that's the way we get there.
Thank you so much. I guess the question, the reason why I'm asking it, right, is where does the liability stand if a provider inserts in the EHR, this patient suffered from this, or this is the altercation that we had as part of the medical record, so that way we can better treat them. And if the patient disagrees with that being put in there, right, does that open up the liability for providers in terms of what are we storing into the record that we use to communicate between provider to provider? And maybe we can talk offline about that, but I know that's probably one of the biggest challenges. The other challenges that I wanted to talk about are the operational challenges. I think so in real time, right? I think all of us agree that patients should have access to the data 100%. But I think there's a delineation as to what's feasible and what's not feasible, right? In general, at least on the primary care side, I think the metrics that we try to guide ourselves with is 3 days or 48 hours maximum for stat medical record requests, and 7 days as a request just in general for any medical records requests. That's the timelines that we adhere ourselves to. Does it always work that way? No. And I think there's always patients that come in and ask us and say, I want my records right now. I need them. And so I guess the question becomes, how do we ensure that we're not putting our providers in operational deficiencies? Because the way that I'm reading the bill is that you have to provide an unimpeded, secure access. And so if a patient's right there asking for it, does this bill now require us that we have to drop everything else, regardless of the patients that we're taking care of, to now serve access to the medical record, versus if we had timelines, maybe that would be easier. So,
Senator Lang, for the record. So you ask a really good question, and I can only relate it through my primary care doctor. She comes into my exam room with a computer. She's writing on her computer all the time. Before I leave that office, I can go on and look at her notes for my visit. And so it may be a change in paradigm to how physicians are used to doing things, but as I visit many doctors, a lot of them are doing this very same thing. And so the records are immediately available to people because they have an app, or, they have access to those records.
Thank you so much. I think so I'm trying not to go down a rabbit hole. There's another issue as to whether or not medical records should be immediately released. I think that the struggle that some physicians may have, or providers may have, is sometimes you don't want to release lab results immediately to patients when we receive them, because you want to be able to communicate the diagnosis to them, especially if it's a life-threatening diagnosis. And so I guess what I'm worried is, if this law is structured that you have to provide the unimpeded access, do we set ourselves up to be in a position where, I mean, clearly everyone agrees that everyone should have access to that information, but is that the best level of standard of care if we're not able to get ahead and actually provide that patient the comfort that they need for when the diagnosis comes through?
Senator Lang, for the record. So I live by my test results. I get my test results from Quest before the doctor gets them. And then we have a conversation. I always have an appointment set up afterwards, so we have those conversations. I see where you're going, because, like, if there are not great results, do you want the patient to have that before they have a chance to talk to the doctor? I think these are some of the questions that DHHS can answer with the committee and when they give reports. I'm not going to be Pollyannish about this. There are lots of things we need to work through, but it has to start somewhere, that people can get to their medical records when they need to get to them.
Thank you, Senator Lang. I think the only thing, and Paul and Tom, I don't know if you have any other comments or anything, but the main thing of what I'm trying to get to is, I think if we were to, maybe as we're working through the amendment, it could be that DHHS has to prescribe regulations in terms of what is fair in terms of how long patients have to wait before they access their medical records and the mode of transmission, right? So if a patient wants their electronic health records, then how do they do that? Is it through an encrypted email? Is it through an encrypted USB device? Is it through a secure file? Like we use Box, right, in primary care. And so there's a lot of convoluted structures, and I think that the timelines and the mode of distribution is obviously, I think, something that we can definitely work on. But I just wanted to have the more of the discussion of if we actually give ownership to the data ownership to the patients, does that set us up to, are we prepared for the operational and the legal concerns that will arise from it, right? And so that was just more so the line of questions, but I understand your intent, and I think we all are kind of in agreement of it. So I don't know if there's any other further questions. Seeing none, all right, let's go ahead and open it up to testimony and support, and then we'll go to testimony in opposition. Because we are in a weird time flux, I am going to limit it to 15 minutes each. So 15 in support, 15 in opposition, and then 15 in neutral. So folks can please come forward if you would like to testify in support of this bill. I don't see anyone here in Carson City. Is there anyone in Las Vegas? AVH, is there anyone online?
There are no callers in support at this time.
Thank you so much. Let's move on to testimony in opposition. If you're in opposition to this bill, please come forward. And we'll begin here in Carson City.
Almost said good afternoon. Good evening, Chair Donyate and members of the committee. For the record, my name is Donna Laffey, here on behalf of AHIOS, which is the Association of Health Information Outsourcing Services. AHIOS is currently opposed to SB 250 as written. More specifically, we're concerned with the broad language in Section 3, subsection 2 and 3. We have concerns about data privacy and protected health information being forwarded to undefined third parties, as well as the costs that are involved with protecting that information as we transmit those records. We want to thank the bill sponsor for working with us. We really appreciate the conversations that we've had and look forward to continuing those. Thank you.
Mr. Chairman, members of the committee, my name is Janine Hansen. I'm the state president of Nevada Families for Freedom. We were here for the discussions last time on SB 7. We continue to have problems about electronic records, and the reason is because like this bill, we opposed the repository. We're glad that it's out of the bill. But when you look at Section 19 of the new bill, it says any recommendations for legislature on administrative changes necessary to ensure effective implementation. What this appears to be is just a way to get to the electronic sharing of health records. And we hope it's not. We hope that there will be alternatives. We want to be sure that privacy is maintained and that people their records and their health information is not being shared in any way they don't have control over. We really liked what Senator Titus said about people having control and they could take it to the doctor, but we don't want any government database or government repository of any kind that this could lead to in order to control our health records. There's a lot of things for individuals that could be discriminated against because of certain things in their health records and other problems. They may not be able to get a job or some other issue because of something in their health record if it were available or it became available through hacking or whatever other means to people who were not authorized to have it. So we appreciate your careful consideration of our concerns about privacy on this bill. Thank you.
Good evening, Chair Donate, members of the committee. For the record, David Cherry, Government Affairs Manager for the City of Henderson. First, I want to thank Senator Lang for meeting with me before today's hearing and really discussing the goal of her legislation. I'm here in light opposition to the bill as written because of concerns from the City of Henderson regarding certain requirements in the bill, especially on our fire department, which provides emergency medical care through our EMTs and paramedics. We are hopeful that the amendments to the bill can address these issues, and we really appreciate the thoughtful discussion today surrounding the concept of who owns medical records versus what is full access to health care information. So we're optimistic that we can get to where we need to be on this bill, and thank you again.
Evening, Mr. Chairman. Sean Meehan, and I am testifying on behalf of the Nevada Republican Party. From 2012 to 2022, I was the chairman of the Resolutions Committee. In 2022, we passed a resolution at our state convention regarding a medical bill of rights that we were going to ask the legislature to pass. And I have excerpted just a very few bullet points that I think are salient to this bill. And they read as follows: that patients have the right to read and copy your medical records and have your records made available only to persons and offices that you designate, the right to talk privately with healthcare providers, no government involvement, the right to ask and be informed of any business relationships to include financial incentives between the hospital and educational institutions, pharmaceutical companies, governmental entities, other healthcare providers, or payers that may influence your health care and treatment, and this resolution passed unanimously. I noted that this, as originally written, contained an unfunded mandate, and in a year where we all know there's going to be some budget challenges, obviously that's something we wanted to focus on. I wanted to ask if there's clarification on the conceptual amendment, if that is likely to pass, has already passed or not, because we very much like those changes. It took away the big problem, as previously stated, about privacy and government ownership of a medical database. This is a huge problem. I found it interesting that the presenter said that currently there was over 100 providers they're already working with in Las Vegas. 40 tax IDs was an interesting statistic. They're doing this now and it works without any legislation from you all. The free market saw a need and it filled it. We could maybe keep going in that direction and encourage this company to keep doing good work. I get my health care from the Veterans Administration, so I have some unique experiences, real life with this. I get great care, but sometimes the medical records are a huge problem. I think some of you are aware that they're saying it's going to be another 6 years and $50 billion to even try to get it right. This is something you have to be careful of. Also, when you create a database, you have to be careful. Back in the early 1990s, I was an enlisted flight crew member, and we were ordered by the Pentagon to give DNA samples in the event of a tragic aircraft mishap so that we could be identified. We signed a form. I was threatened with a court-martial because I stood up to my commander and said, I'm not giving you my data because I don't trust the government. There was a big paragraph that said this will never be used for anything else. Within 2 years, the Supreme Court decision directed that database be dumped into a regular database. And while I'm all for rapists being identified and prosecuted.
If you can please complete
Yes,
your
sir.
remarks.
You create a database, you create somebody that wants it unknowingly. I'm glad that we're going to do that. And also, there were VA records on laptops stolen from a contractor's vehicle. We have to be careful about things like that. I hope the amendment passes. I think we need to encourage the private market and maybe an industry working group with medical professionals not bothering the legislature about this. Thank you for your time, Chair.
Thank you, sir. Anyone else here? Seeing no one here or in Las Vegas, AVH, is there anyone online?
Chair, there are no callers at this time.
Thank you so much. Let's go on to neutral testimony. If you would like to testify in neutral, please come forward. Both here and in Las Vegas. Let's start with Carson City. Please begin.
Chair Donate and committee, Shelley Capurro representing Healthy Nevada. And we are here today we're happy the conversation is going on. We want to thank Senator Lang for having conversations with us and the proponents. And Healthy Nevada is the state's only certified nonprofit statewide health information exchange, and for over a decade, they've been providing real-time health data to thousands of providers while respecting patient consent to exchange and patient autonomy. While participation in Healthy Nevada's exchange is voluntary, it has already been widely adopted by thousands of healthcare facilities, providers, and health plans throughout the state, and state agencies depend on the exchange services that it provides. It has the highest level of security and the highest technology certification, and it enhances care coordination, patient safety, and transparency and efficiency across our healthcare system. In regards to SB 250, Healthy Nevada does support ownership of records by patients, access to them, and in regards to the repository that was in the first version of the bill, they think that would have been a great step towards aligning Nevada with the vast majority of other states, putting us more in line with national interoperability efforts. Finally, HIEs have reduced costs and saved lives, and we urge the legislature to continue this conversation and move forward with cost-effective solutions that will improve patient care and make the lives of providers easier. And if you have any questions, Healthy Nevada's legal and technical expert can call in. So if you guys have any questions about Healthy Nevada. Thank you.
Maya Holmes, Culinary Health Fund. Our name has been batted around a little bit today by some of the guest presenters, and I just wanted to clarify that I'm the person representing the Culinary Health Fund today. We really deeply appreciate Senator Lang's intent and commitment to patient electronic health record access. We want patients to be able to access, retrieve, and forward their medical records when they want and need to. We've been in discussions with the sponsor on amendments that will support work already underway, and we appreciate having ongoing discussions with her on the bill. We support building on interoperability, which was the focus of AB 7, the patient protection bill from the last session that was enacted, and not data repositories managed by third parties. We really look forward to continuing our discussions with Senator Lang and appreciate her consideration of our concerns. Thank you.
Thank you so much. Let's go down to Las Vegas, please.
My name is Stacy Sasso, Executive Director for the Health Services Coalition. The coalition represents 27 employer and union-sponsored, self-funded health plans in Southern Nevada. Our member groups include municipalities like Clark County and City of Henderson, building trades like electricians, plumbers, and Teamsters, as well as hospitality groups like MGM, Caesars Entertainment, and Culinary Health Fund, to name a few. Collectively, our groups covered just over 300,000 lives. We're here in neutral today on SB 250. We are pleased to see the work the Patient Protection Commission did in the 2023 session in bringing forward AB 7, which was enacted. The regulations under that bill were just recently approved, and we're supporting additional improvements in the regs this session. We're very focused on ensuring patients, not a third party, are in control of where their medical records are sent. We do not support the storage of patient records in a private repository, but we support the sponsor's intent to secure patient access, and we appreciate discussions with her to move in that direction and understand it is the sponsor's intent to not create a separate repository. While we have not had time to fully understand the amendment, we appreciate the effort and want to continue to work with the sponsor on this bill. Thank you.
My name is Nicholas Rogers with United Association Local 525 Plumbers, Pipe Fitters, and Service Technicians. And we believe patients should be in control of their own medical records, not private companies. We appreciate the sponsor hearing our concerns, and we look forward to continuing working together in the future. Thank you.
Thank you so much. Anyone else in Las Vegas? AVH, is there anyone online?
Chair, there are no callers in neutral at this time.
Thank you so much. Senator Lang, do you have any closing remarks?
Senator Lang, for the record, thank you so much for taking the time to hear this bill, because I believe that we have to start somewhere. And I think it's worth repeating that there is no government repository. It is out of the bill. I heard the people that emailed me and testified today, and I think it's worth repeating that Section 19 that's been added to the bill requires the director of HHS to submit quarterly reports to the interim Health and Human Services Committee detailing the progress made toward implementing the provisions of this act. So people won't be held in the dark. They'll be able to have input, and we'll be able to move this bill forward, the act forward in the interim, and hopefully move us closer to what our goals might be. Thank you.
Thank you, Senator Lang, and thank you so much to your co-presenters on this important piece of legislation. I'm going to go ahead and close this bill hearing and move on to our next agenda item. Committee members, before we go to public comment, I do have 3 bills that were referred to our committee for introduction, and so we are going to go through this process of introducing the bills. Committees are asked to introduce BDRs to begin the bill process, assign a bill number, and get it referred back to our committee. Just as a reminder, your vote to introduce a BDR is not an indication of your support. It's just to get the bill printed and assigned a bill number. The first one is BDR 40-559. This bill revises provisions relating to county hospitals and county hospital districts.
So moved.
We had a motion from Vice Chair Taylor and Senator Stone seconded. Any discussion on the motion? All those in favor, please say aye. Aye. Any opposition? Seeing none, we'll go ahead and move on to the next one. Our next BDR is BDR 38-357. It revises provisions relating to the reporting of investigation of child abuse or neglect.
So moved.
We have a motion from Vice Chair Taylor and our second from Senator Titus. Any discussion? All those in favor, please say aye. Aye. Any opposed? Motion's carried, and we are now moving on to the last one. This is BDR 23-562. This revises provisions relating to public employees.
So moved.
We have a motion from Vice Chair Taylor, second from Senator Stone. Any discussion? All those in favor, please say aye. Aye. No opposition, and the bills have been passed for introduction. And now we are at public comment. If there's anyone that would like to provide public comment, please come forward. Seeing none, or in Las Vegas, AVH, is there anyone online?
If you'd like to participate in public comment, please press star 9 on your phone to take your place in the queue. Chair, the public line is open and working. However, there are no callers at this time.
Thank you so much. That concludes our items for today, and we'll see everyone on our meeting on Thursday, March 20th at 3:30 p.m. Meeting's adjourned.